Today's speaker is B. Douglas Hoey, a registered pharmacist and MBA. He's also the CEO, the Chief Executive Officer for the National Community Pharmacists Association, or NCPA, which is where I did my residency and which is why I'm here in the DC area. Douglas Hoey is the Chief Executive Officer of the National Community Pharmacists Association. The National Community Pharmacists Association represents the owners of nearly 19,400 pharmacy small businesses. These pharmacies are important to local economies, providing jobs for more than 240,000 people, and are consistently ranked by consumers as the top-rated pharmacies in the country. Hoey is a licensed pharmacist in Oklahoma, Virginia, and Texas, and practiced in a variety of community pharmacy settings, including his own family's pharmacy before coming to NCPA. He is widely quoted by media as an industry expert on community pharmacy practice issues, including drug supply and prescription drug pricing. Hoey also developed and taught pharmacology courses at George Washington University and Marymount Universities. He is president of the World Pharmacy Council, co-chairman of the SureScripts Board of Directors, chairman of the NCPA Innovation Center, and vice chair for the CPESN USA Board of Managers. His pharmacy degree is from the University of Oklahoma College of Pharmacy, and his MBA is from the Oklahoma City University School of Business. Please join me in welcoming Doug Hoey.
Well, thank you for the invitation to speak with you today. As Alexander mentioned, I'm a pharmacist. My name is Doug Hoey with the National Community Pharmacists Association. We're headquartered in Alexandria. We've been around for almost 25 years, and we represent pharmacy small businesses. But my comments today are going to talk a little bit about pharmacy small businesses, independent pharmacies, but really about community pharmacy overall. Because drugs are in the news a lot, especially during the pandemic, where you couldn't sneeze without, well, you shouldn't, sneezing really is frowned upon these days. But with the COVID vaccinations, with monoclonal antibodies, and of course that continues to be in the news, flu vaccines, treatments for RSV. Today there was in the news about the possible vaccine for RSV, shortages of ibuprofen liquid and acetaminophen liquid, a new Alzheimer's drug that could potentially slow down the progression of Alzheimer's. Drugs are in the news all the time, and community pharmacies are a great asset for communities needing these valuable medications. So that's the premise of my presentation, and I'm going to really look forward to some time for Q&A as well. Just a little bit about pharmacists. Alexander is a pharmacist, as he said, went to at least 6 years of training to become a pharmacist. It's a minimum of 6 years to get a degree. And we do pretty well in the most trusted professions. We're actually down a little bit. We were #1 every year until they introduced nurses, and now nurses are #1 every year. And then we were #2, and this is an anomaly that the doctors and grade school teachers hopped over us. But we've been in the top 5 for about 50 years, so pretty good. Politicians.
Yes, sir.
As far as the rankings of most trusted professions, politicians are the lowest.
Oh, that's good to know.
Yep. Just an example of what independent pharmacies look like. So in this market, chains dominate Washington, D.C., the Washington, D.C. area. Everywhere you go, and I'll get into that in just a little bit. And there's about 25 to 30 independently owned pharmacies in this area. Across the country, 1 out of every 3 pharmacies in the country is independently owned. So people think, and I get this all the time, are there any independent pharmacies left? There are. They're just not at the most primo real estate. They're not on K Street. They're not on Connecticut Avenue. Actually, they probably are a couple on Connecticut Avenue. But they are around, and they're very innovative. And in fact, a lot of our members are Rotarians, because small business, giving back to the community, is something very much that's part of what they do. And just to that example, independently owned pharmacies are about half versus the chain. So this doesn't count like the grocery stores and stuff like that. So that's Walgreens, CVS, Rite Aid, all the independents. So there's a lot of them, just not necessarily, again, on the corner of main and expensive real estate. So the average independently owned pharmacy fills about 60,000 prescriptions a year. For a chain, it's often around 100,000. But it's still a lot of patients coming in, taking care of, pharmacists taking care of. The average prescription charge is about $60. And I included that because some people may go, wow, only $60? And some people may go, geez, $60, depending on your experience. Because you may have been to the pharmacy just recently and your bill was $400 and you're saying, wow, I wish I had one of those. Or your bill might have been $2.29 and you say, wow, why was that so expensive? And that's something that's happened in prescription drugs, is that they have gravitated to become either very cheap or very, very expensive. 90% of all prescriptions filled in America are for generic drugs. 90%, 9 out of 10. Not all of those are extremely expensive or extremely inexpensive, but many of them are. So you have really this polarization, like a lot of things in our country, of really inexpensive or really expensive. Those really inexpensive drugs are the yesteryear's Lipitor, Zestril, Prenavil, good drugs, good medications. They've just become generic now. 54% of prescriptions go through government programs. And I say that with neither good nor bad, but it's a reality that when we talk about government healthcare, good or bad, 54% are already going through a government program, which is new. That's been in the last 20 years. It hasn't always been like that. So it's made our industry even more complicated and even more political. Overall, just as the independent pharmacies are about a $78 billion marketplace, overall prescription drugs in this country are about $500 billion, about $500 billion. That's before the rebates, which that's a whole nother nuance of our industry. But about $500 billion goes into prescription drugs. About 80 go through the independently owned pharmacies. One thing about the independently owned pharmacies is that we are often in socially vulnerable areas and in populations that are under 50,000, but also, especially in a big area like DC, where there are socially vulnerable populations, you'll often see independent pharmacies there, again, not only DC, but throughout the country. So that's a real important gap that these community pharmacies fill for healthcare in the United States. And as I mentioned, over 50%, the two government programs that are the biggest are Medicaid and Medicare. So Medicare is about 33% of all the prescriptions filled are Medicare. But remember, Medicare didn't cover prescriptions until 17 years ago. It's only been in the last 20 years that Medicare got into the market, and it's 33% of all the prescriptions. Medicaid is about 15 to 17%, and that's continued to grow. One important thing, I mentioned independently owned pharmacies, community pharmacies, very much tied into their community. They live and breathe in their community, the success of their community, their neighborhood, they're part of it. 65% give some kind of monetary support to 5 or more organizations. Sophia mentioned Meals on Wheels as one great example, a great service, whether it's that or the soccer team or the PTA, they're very much part of the community. They'd be a big, I think of the movie It's a Wonderful Life and George Bailey, that if these people weren't around, it would be a huge gap and there'd be some more Pottervilles around. Now this is a pivot here that's important to note, not only for independently owned pharmacies, but for all of pharmacy. Pharmacists are much more involved with primary care services. So what's primary care service? Primary care service, we're not diagnosing diseases. Doctors do that. We are the medication experts, and there's a lot of things that require medications. And there's really a primary care crisis, in my opinion, in the United States. There's a shortage of primary care physicians. They're being often supported by nurse practitioners and by physician assistants, but even so, primary care is in short supply, and pharmacists are help filling the gap. During the pandemic, pharmacists gave over 300 million COVID vaccinations. That's over half of all the COVID vaccinations in the country were done by community pharmacists. I would my opinion would be that without community pharmacists and the COVID vaccinations, we'd be a year behind where we are today, which is pretty much ahead of the rest of the world. We do blood pressure monitoring. A collaborative practice agreement is when we get with the doctor and say, look, for your patients who come in, will you give me permission to go ahead and make this decision, and I'll tell you later what I did. For example, adjusting an insulin dose. That patient comes in on a Saturday, doctor's not there, the pharmacist works with the patient to adjust an insulin dose, then tells the doctor what happened, doctor signs off on it. 43% of pharmacies have that type of arrangement. So primary care is really becoming important. And that's been noticed from a business standpoint by the really big companies. So Aetna, CVS Health, so CVS Health owns Aetna, not the other way around, by the way. And they're, I think, a Fortune 5 company. They're almost a $250 billion company. Because they own Aetna, which provides insurance, they own brick and mortar CVS's, and they own the middleman in between the patient, the pharmacy, and the pharmaceutical manufacturer. They're able to help steer where that patient goes. So if you have health insurance with Aetna, you may be encouraged to use a CVS. Your insurance plan that decides which drugs are covered may say, well, we're only going to cover drugs that Aetna wants us to cover. It's very much a vertical integration. CVS Aetna started minute clinics about 15 years ago. Those are continuing to grow. This is a quote from their CEO that they're going to expand primary care for lower risk patients, and pharmacies will serve as the next step. And they're going to expand their minute clinics. So that's something, minute clinics, we kind of already knew that with CVS. They've laid out their strategy, but primary care, because primary care is a key to controlling where that patient goes, whether it's a hospitalization, outpatient, a specialty drug. Walmart has said they're going to build 4,000 primary care centers near their stores, which will include imaging, so x-rays, well, not really x-rays anymore, but imaging, dental, laboratory, and primary care. So Wall Street's definitely heard it. Walgreens is buying primary care. So they're getting into the primary care business. Amazon bought a primary care telehealth company for $3.9 billion a few months ago. And then our independents, we're pooling together in groups to provide primary care. So I emphasize this so much because a lot of times people think about pharmacies and they think about getting pills. And that's still true, but it's so much more as far as primary care, where your pharmacy may be your closest first step, maybe before you go to your physician or to support what your physician is doing. So that's a new trend, newish, and it's something that I think you'll see over and over again, and it's really important for the health of our country. Because, and I skipped over it, the shortage up here, the Association of American Medical Colleges expects the US to face a shortage of primary care physicians ranging from 20 to 55,000 in the next 10 years. So there's a shortage of primary care physicians. So primary care is key to controlling the patient's journey. One thing I included, because it's DC, it seems like there's a lot of CVS's around here. Well, if you thought that, you're exactly right. The market share in DCA, so I was in anticipation for this. I've never looked at this question before, but I thought, when I come and talk to DC, it seems like there's a CVS on every corner. DC has the highest CVS market share of anywhere except for some places in Massachusetts and Hawaii. So CVS is based in Rhode Island next to Massachusetts. So Boston's higher by 1%. Worcester, I think, is higher by 2%. So if you thought, man, there's a lot of CVS's around here, you're exactly right. So for whatever reason, maybe because of the big domed buildings we have behind us, they've really decided to have a lot of market share here. These are just some other markets. Like Baltimore, it's 30%. Just kind of point of interest. I'm not sure what you do with that. Wow, your friends. Total prescription prices. Why do prescriptions cost so much? That's, usually you get to prescription drugs and it's the first or second or third question is, why do they cost so much? Well, it can vary widely. And there's a lot of controversy now that people are finding that when they use their health insurance, they actually pay more than if they didn't use their health insurance for some drugs, not for all drugs, in particular for generic prescriptions. And people are finding this phenomenon, and some of them are pretty put out when they say, well, wait a second, I'm paying premiums every month for my insurance. Why is it less expensive for me to buy it without my insurance? This chart here is from Consumer Reports. It's from May of 2018, so it's now 5 years old. They did some secret shoppers for a market basket of 5 commonly used drugs. And they went to different pharmacies, and this is the total amount each basket of 5 drugs cost. At a Costco, I think it was $105. At a group of independents, it was $107. There's a range there because every independent is independent. Walmart was about $700. Walgreens, I think it was about $900. And CVS was just over $1,000. So it does make a difference to shop around and to even talk to your pharmacist about where you can get your best deal, and whether using your insurance makes sense to get your best deal, especially if you have a generic drug, But even with the brand, because there's a lot of coupons for brands that the manufacturer provides, and some pharmacists are very helpful with that to help you find out. This one that I'm going to show you is pertinent to how PBMs work. So PBMs is not a word I've used yet so far, but those are the pharmacy benefit managers, and they control drug pricing in the United States. They're companies you've never heard of probably, like Caremark, which is owned by CVS Aetna, Optum, which is owned by United Health, and Express Scripts, which is owned by Cigna. They're all owned by the big insurance companies. So again, Dr. Flannery, Dr. Glaucoma-Flecken, he has millions of viewers. He explains PBMs in 2 minutes. It's taken me 25 years and I still can't do it, but he does it. So I'll let him speak for himself.
Hey, boss, you got a second? Oh, hey, Jimothy. Yeah, what's up? Well, a lot of our customers are pretty upset about the cost of their prescription medications. Yeah, I bet. They're super high. Is there anything we can do to help bring that cost down? Oh, you're going to have to talk to the pharmacy benefit manager about that. What is that? The pharmacy benefit manager. The PBM. Jimothy, did you not study your health insurance chain of command? The PBM negotiates discounts with the pharmaceutical companies. Oh, and then they pass those savings down to patients? Oh, God, no. Ugh. No, they pocket the money, reap enormous profits, which actually increases the cost of medications to patients. Really? Yeah. PBMs run every aspect of the drug market. They set prices and they determine which medications will be covered by your insurance, all to the highest bidder. Oh, God. Well, do you know where I can find one of these pharmacy benefit managers? What's happening right now? Hi, I'm the pharmacy benefit manager. I'm confused. Jimothy, it's actually me, United Healthcare. Yeah, I know. You're also the pharmacy benefit manager? Yeah. Well, we go by Optum, but it's all United Healthcare. Anything else you own? Oh, we have our own pharmacy, Optum RX. Yeah, all our customers have to use it. It's great. So let me get this straight. The PBM, that's me, decides which medications are covered by health insurance, also me, and which pharmacy, me again, the patient uses to get those medications. Vertical integration. We make $200 billion a year. It's awesome. Surely there's some kind of oversight, right? Somebody has to keep you accountable. You don't make $200 billion a year with oversight. How is any of this legal? Jimothy, when you make enough money, you get to write the laws.
So it's a complex market. There's a lot going on with prescription drug pricing. That's why it's one of the reasons why prescription drugs do cost so much. It's very, very complex. The pharmaceutical manufacturers, the insurance companies, they're duking it out all the time, and pharmacies are trying to do the best they can to get the right drug. That's the most important thing to us, is that that drug be effective for the patient. This is our building outside of Alexandria, and that's my contact info. And that's a 6'4" Norman Rockwell statue that is the pharmacist dispensing medication for this sick little boy.
Yes, thank you for your talk. I wanted to just ask a quick question about where you ended, and that is the Federal Trade Commission is looking at the rebate walls and PBMs. Is your organization taking a position on their work?
Very strong position on that. In fact, the chair of the FTC was at our annual meeting. I interviewed her on stage. It is, I actually didn't bring that up at this meeting, but yeah, the FTC has kind of cast a blind eye to this for decades, but they seem interested in the impact on competition and the impact on patients of some of the things that we're seeing.
Yes, my wife and I had to take a trip recently, and we needed a PCR test. And so we went online, trying to get an appointment. CVS got an appointment for my wife. We given our Medicare information. I go to the local community pharmacy, same process. CVS, no cost. The local pharmacy, $75. What's happened there?
So back to that vertical integration. So depending on who you're using for your primary care insurance, they could have a preferred pharmacy. So from our vantage point, it's being able to steer that patient into the pharmacy of their choice. And one way they can steer a patient is by charging you more to go to another pharmacy. So it's not the pharmacy necessarily charging, especially if you're using insurance. The insurance company decides what to pay. They also decide what to charge the federal government. There's limits on how much they can charge the federal government that are caps. But you probably went to a pharmacy that was out of network, is probably the short answer. But it's a tool that can be used to, you're going to go to wherever you can pay a zero copay versus something else. So it's a tool that can be used to steer you to where they want you to go. It's an effective tool.
Question. What's a good RX and how do they fit into this thing?
That's a great question. GoodRx is they're now publicly traded. They were a private equity company, and they do discount cards. So they're on TV all the time, talking about how pharmacists love these cards. We hate these things. And I think I speak for the chains when that too. So the GoodRx, they do a deal that says they're going to try to charge less for a generic drug. They'll do if you look at their website, they'll list pharmacies where you can get the drug at a certain price. So those pharmacies pay a fee to be listed on that list. When the patient takes that card to the pharmacy, we send your information, the processing of the prescription, to GoodRx, and they send us back how much to charge. GoodRx, frankly, can be a less expensive solution, whether it's GoodRx or another. The reason we don't like it is because some of our cash prices may already be that cheap anyway, but GoodRx takes 15%. And then they also take your information, and then they know where to find you, and they start marketing to you. So those are two of the reasons we're not crazy about them. They also will give some of their money back to the PBM. So the PBM helps too.
One last question.
Yeah. I'm sorry I don't have like a simple answer to that. Oh, yeah.
You got to do the wrap, but you got a quick question?
Okay.
Very quick.
When I hear about drugs on the news, I think of the opioid crisis, which is out of your scope, I think, but can you say something about it?
It's horrible. I will say one thing on the opioids is that one positive thing is that we've seen a switch from so many of the deaths from the oxycodones, the hydrocodones, from legitimate sources, and that there's still room to be worked on there, improvement to be made. But unfortunately, now a lot of those patients are no longer able to get the opioids and hydrocodone, and so they've switched to heroin and fentanyl. And so the deaths have continued, which are horrific. And as a pharmacist, we hate seeing good drugs, not that heroin is necessarily a good drug, being used for abuse purposes. It's a huge issue. I think it has both, there's economic reasons for it, there's societal reasons for it, but it is something we're going to have to deal with as a country because of the horrific impact it's had on our nation.
And it's our practice with all of our speakers, particularly good ones like you, to plant a tree in your honor with our Trees for the Capital campaign. We've been doing this since the early 1990s, and about 45 trees a year.
That's wonderful.
Every week. And we got this cool certificate for you. You can hang it up on the wall.
Thank you.